being recorded.
Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, I wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you direct to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speaker. Joining us today, we have Dr. Colleen Harrington. Dr. Harrington is a cardiologist and faculty member at Mass General. She is one of the associate program directors of the MGH Cardiology Fellowship and the Cardiology Clerkship Director for Harvard Medical School. She is the current governor of Massachusetts chapter of the American College of Cardiology and serves on several ACC national committees, such as the Cardiovascular Disease in Women Committee and the Cardio Obstetrics Work Group. Her clinical and research interests include heart disease in women and valvular heart disease. In recognition of Go Red for Women, which is this Friday, she joins us today to give a talk on sex differences in heart disease. So please join me in welcoming Dr. Harrington.
Well, thank you, Amy, so much. One, for the invitation. It's just an honor for me to spend the next hour with all of you and the Blum Center for their focus on education of cardiovascular disease in the community. So I'm just going to share my screen. Let's see if this will work now. And Amy, can you see my screen? Okay, perfect. So again, really just an honor for me to be with all of you today as we kick off February as Heart Health Month and increasing awareness of cardiovascular disease, not only in our community, but nationally and internationally. And the Go Red for Women, which is February 3rd, just such a perfect timing to talk about staying healthy and sex differences in heart disease. I have no disclosures relevant to this talk. So in this program, we're going to discuss heart disease trends in men and women and focus on women in particular. We're going to talk about some sex-specific features of cardiovascular disease. We're going to really dive into some cardiac risk factors and increasing awareness and even some ways on how to address them. And then lastly, we're going to talk briefly about some sex-specific disparities in cardiovascular care and ways that many of us in the cardiology community are trying to address them. So trends in heart disease. So according to the WHO, cardiovascular disease is the leading cause of death globally, estimated to cause almost 18 million deaths each year. And when we talk about cardiovascular diseases, we're talking about disorders of the heart and blood vessels that cause heart attacks and strokes. There can also be issues with heart valves, which direct blood flow through the heart. We won't dive too much into that today. So more than 4 out of 5 cardiovascular deaths are due to heart attacks and strokes. And unfortunately, we're seeing more now that these are occurring in patients under the age of 70. This is a global map showing cardiovascular disease, both in men and women. In red is a very high number of death by cardiovascular disease, particularly in North Africa, Eastern Europe, and Asia. Although the United States is in the gray, it is the #1 cause of death, and so we have lots of work to do. Now, when we look at internationally, what are the top 3 causes of cardiovascular death? #1 is ischemic heart disease, as outlined in dark blue, and that's usually referencing something called a heart attack. #2 is stroke, and #3 is hypertension, or also when your blood pressure is elevated. But the important point and things I really want to drive home today is that recognition of cardiovascular risk factors and addressing them, we can have a huge impact on these numbers because 80% of these could be prevented. Let me start back to just start by showing again that cardiovascular disease is the leading cause of death globally, most usually caused by disorders of the heart and blood vessels. And the most common, or 4 out of 5 cardiovascular deaths, are due to heart attacks and strokes. And again, unfortunately, we're seeing these in patients under the age of 70, and that's increasing. And this is the world map. Again, I apologize that you weren't able to see that. In red, showing very high numbers of cardiovascular death in North Africa, Eastern Europe, and Asia. Although the United States and Canada are in the gray zone, it doesn't say that our numbers are low. Actually, cardiovascular death, unfortunately, is the #1 cause of death, as I mentioned. Again, this is the top 3 causes of cardiovascular death in the world, with ischemic heart disease causing heart attacks. Usually that's what we're referring to. Also stroke, as well as high blood pressure or hypertension, which is often unrecognized and underdiagnosed. And as I mentioned, you have a huge impact and prevention of cardiovascular death by recognition and addressing cardiac risk factors. So let's talk about cardiovascular disease in women. So 9 million women died from cardiovascular disease in 2019. It's caused about 1/3 of deaths for women worldwide. Unfortunately, we're starting to see a stagnation in trends that were initially favorable. And in general, women are underdiagnosed, undertreated, and understudied in clinical research studies. This is data on the right-hand side from Dr. Woods, who's part of our faculty at Mass General, showing the prevalence of cardiovascular disease in men and women. This is 2020 data. And if you look below the figures, actually the mortality after or death after a heart attack, still pretty high for both men and women, but much higher for women. And now looking at it from a global perspective, this is the number of cardiovascular deaths per 100,000 people in women, with US and Canada being around 100 to 200 deaths per 1,000 women, and higher numbers again in those regions that I said internationally for men and women. So this is just to give you a global perspective of the impact of cardiovascular disease on death. And unfortunately, cardiovascular disease mortality or death from heart disease in women is increasing according to the WHO. The lines on the left-hand side of the graph of a US female is highlighted in green, and a Canadian female in solid blue, showing that increase from 2001 to 2016. So cardiovascular disease is the #1 cause of death in women. This is data from 2016, showing the top 4 causes of death for women in the United States, followed by chronic lung disease, lung cancer, and then breast cancer. And I'll just point out that the 2nd, 3rd, and 4th combined still do not equal the number of cardiovascular deaths for women. Not to say that all of these are important for not only just heart health, but health in general, but again, to show the impact of cardiovascular disease in women. This is data from 2020 showing very similar, so more recent data, and this is even when we had some data from COVID this is from 2020, so very early into the pandemic. And again, cardiovascular disease #1, followed by cancer, with breast cancer being about 43,000 and about 290,000 deaths. And another trend that we're seeing is that heart attacks, also called myocardial infarctions, are increasing in young women. And this is data showing on the left, French women under the age of 65, and on the right, American women under the age of 55. And we're starting to see an increase in hospital admissions for heart attacks in women under the age of 55. So now that we talked about some trends, we want of heart disease, not only just internationally, but in the United States. It's now important to talk about some sex-specific features of cardiovascular disease with regard to women. So this is a very old image from Netter, which is a lot on, if on the call went to medical school, a very famous illustrator, showing the classic symptoms of a man grabbing his chest, you know, walking out of a restaurant. And well, that may not be so classic, but you know, maybe he had a large meal. We don't know to speculate too far into the picture, but showing that classic chest pressure, squeezing type of sensation that actually both men and women actually feel when they're having a heart attack. So in general, men and women will have chest discomfort, can also, as I said, described as squeezing or pressure. They usually don't describe it as pain, but again, everyone is different. So by and large, that is the most common symptom, but women could have atypical symptoms. And what we mean by this is some of them can be very nonspecific, like fatigue, which can be caused by many things. Nausea, which can also be caused by many things. Lightheaded or dizziness can also be a presentation of a heart attack. Sweating or shortness of breath, or if you have upper body discomfort. So now that we talked about maybe some differences in how women and men might present, what exactly is a heart attack? We hear about this all the time in the news. People talk about this, so-and-so, my friend had a heart attack, but what does it mean? And so just an overview. So coronary arteries are those arteries that supply the heart muscle with blood so that the heart can do its job to pump blood throughout the body. Over time, it becomes narrowed if you have a buildup of fat or cholesterol and forms something called a plaque. You may have heard this term atherosclerosis. They used to call it hardening of the arteries. There's many terminology for this. But when this plaque breaks, a clot can form, and that can obstruct blood flow to the heart muscle. And that's what causes a heart attack in the most common causes in men and women. However, we're now starting to understand that women, aside from that most common underlying cause, can have other reasons to have a heart attack, like something called a dissection of one of those coronary arteries. Again, those coronary arteries are supplying the heart muscle with blood flow. They can have something called a clot that can come from somewhere else in the body, and that's called an embolism. And they can have also something on the top right that's called a stress cardiomyopathy, or sometimes in the news it's referred to as a broken heart syndrome, that tends to get some press around Valentine's Day, in which the heart is actually stunned, usually from a physical or emotional stressor, and that is more common in women. So we're starting to understand that by and large, this buildup of cholesterol is the most common cause for men and women. But in women, we might see a higher prevalence of other types of conditions that can lead to a heart attack. And so now we're also learning that female-specific cardiovascular risk factors are there, they're present, and they need to be recognized and need to be factored in. So we now know that women who have pregnancy complications, either maternal complications, meaning the mom may develop gestational diabetes or high sugar, preeclampsia, which means they can have elevated blood pressures during their pregnancy, if they have a spontaneous pregnancy loss, and if the infant is born prematurely or small for gestational age, we now know that those women may be at an elevated risk for cardiovascular disease later in life. Women with autoimmune conditions such as lupus and rheumatoid arthritis, which are more common in women, and that chronic inflammation can lead to an increased risk of cardiovascular disease again later in life. Postmenopausal state, whether natural or surgical, usually defined as before the age of 40, can lead to an increased risk as well. Ovarian suppression treatment, medications such as Lupron, and there's many there that can cause this, is also may be associated with elevated risk later on in life. Hormonal status, so premature menarche, or usually defined as having menses before the age of 12, some hormone replacement therapy, and even some cancer therapies, some for breast cancer, can increase risk of cardiovascular disease, either due to the chemotherapy or radiation that was required for that condition. And the evidence to support these female-specific cardiovascular risk factors is increasing thanks to great research that's being done across the world to recognize that these are female-specific cardiovascular risk factors. They must be studied, and it's time to incorporate them when we're seeing our patients in clinic in estimating their individual risk for heart disease in life. I want to touch on briefly what I said about the associated complications with pregnancy and risk of cardiovascular disease later in life. So unfortunately, and I'm sorry that the trends that I'm describing today are not all in the positive direction, but as I always says, attention brings intention, and we can focus on our efforts in changing the direction of these graphs to more positive when we give these talks in the future. So maternal mortality is rising, and that is death during pregnancy or within a specified time of delivery. And unfortunately, the United States is leading the way in maternal mortality. And the number one cause, as pointed out in this arrow, is cardiovascular disease during pregnancy is leading to maternal or death of the mother. Again, focusing that, or just emphasizing, we have a lot of work to do. And we're ready to do that. So now we know those women who even have some cardiovascular disease risk factors, such as hypertension, high cholesterol, obesity, if they do have some cardiovascular or infant complications during pregnancy, we're now seeing, as you can see in that red spectrum, they are at an increased risk of cardiovascular disease later in life. That doesn't mean all of them, it just means that they're at an increased risk. And now we have data to say that their offspring might have increased risk of cardiovascular disease, again, focusing on and emphasizing the importance of prevention. This is studies, and I put the graph up just more for a conversation by Dr. Michael Honigberg, who is a phenomenal member of our faculty as well here at MGH, showing that whether a woman has menopause before the age of 40 naturally or due to a surgical procedure, they're at increased risk of hypertension, high cholesterol, and type 2 diabetes. So the reason I bring this up is because these are sex-specific risk factors that are not always incorporated in traditional risk factor assessment that I think now we're leaning more towards giving more attention for our patients in order to prevent cardiovascular disease. So now let's talk about risk factors for cardiovascular disease. And why is this important? Because it's important programs such as this, not only in February Heart Health Month, but all year round to increase awareness of cardiovascular disease so we can make an impact on those numbers that I just mentioned. And unfortunately, I have data to show that it's actually declining, meaning the awareness that heart disease is the leading cause of death among women. This was a study that showed, particularly in Hispanic and non-Hispanic Black women, had a decreased awareness that, that heart disease was the leading cause of death. So know your risk. The first step is to talk with your healthcare professional. Every patient is different, their health is different, their background is different, and it's important to individualize your care with your healthcare team to identify and control and even prevent risk factors for heart disease. During those visits, they will likely review your medical history. Have you had a heart attack or a stroke? Is there a family history of heart disease? What's your lifestyle like? Do you exercise regularly? Those types of information will be likely discussed during those visits in order to make informed decisions. I put the slides up because these are some of things that we can talk about during those visits. What's your cholesterol level? These are data from, again, a lot of this data is coming from the American Heart Association website, which I'll just point out is an amazing resource for patients in getting evidence-based information about heart disease, as well as Cleveland Clinic here showing what are the cholesterol levels I should be shooting at. What are my numbers? A lot of patients are not aware of that, and it would be important to discuss with your physician what your cholesterol levels are and what your goals might be. They're slightly different depending on your medical history. In general, we do shoot for a total cholesterol under 200. and LDL cholesterol, which is also termed the bad cholesterol, under 100, though it can be less than 70 in some patients with heart disease and stroke. And the HDL, which is also coined as the good cholesterol, the higher, the better if possible. They'll likely will be checking your blood pressure. And I get this question all the time: what's a normal blood pressure? Well, in general, less than 130 over 80 millimeters of mercury on average is a goal that applies to most patients. Please know there's always exceptions based on somebody's medical history and risk factors. They will be assessing your height and weight, and that is one way to calculate your body mass index. So your height, so your weight in kilograms divided by your height in meters squared is, and there's apps on all over the web to calculate this, with a normal BMI about 18.5 to 24.9, and they will assess if you are overweight or obese, likely during one of those visits with your healthcare team. The traditional risk factors, many on the call will likely know, smoking being by far the biggest risk factor for heart disease in men and women, absolutely. High blood pressure, or something called hypertension, high cholesterol, diabetes, so knowing what your glucose level is, and again, if you're overweight, or if the BMI is obese or classifies as obesity. I put this risk estimator, this is on the acc.org. A lot of cardiovascular and internists, and really many physicians and healthcare team members, will use this as a general guide or tool to aid in the discussion with their patients about what is your 10-year risk of having a heart attack and stroke. Again, if you've never had one, so this is in primary prevention, and that's a word that we use in people that were preventing heart disease that has not had a heart or a stroke. And this has been validated for patients aged 40 to about 75 years old. This aids in the discussion in is there some medications that we should be using to control your risk, or maybe not. And so I bring this calculator up during many visits so that patients can see the numbers, we can talk about it. It really does aid in the discussion about what to do next. So I'm bringing up a lot of questions that people ask me in clinic, because I think that's where, when most people have the same questions, I think a lot of people are thinking about the same things. Does it matter what my waist size is? Well, yeah, it actually does. And so in general, and every person is different. Men in general tend to develop more abdominal obesity, more in the apple shaped, where in women, lower abdominal and in the thigh area, which is why the WHO includes the waist to hip ratio to calculate what is an ideal waist circumference. As we know from studies, that increasing abdominal obesity can lead to something called insulin resistance, which means that you might have more elevated sugar levels or glucose levels than what is normal. And so those are there for your reference, and something I try to measure in all my patients as well, and just to guide them into the discussion about their heart health. But in addition to the traditional risk factors that I mentioned, there are some risk enhancing factors that some individuals may have and some may not. So do you have a family history of early heart disease? And this is defined as a male having a heart stroke less than 55 years old, or a woman less than 65 years old. Do you have a very high cholesterol level? That's that LDL or bad cholesterol greater than 160. I'm not asking you, of course, to remember the numbers. This is more just as some reference points in what we think would be a risk enhancing factor, and maybe more likely, not all the time, maybe starting on medication to control that cholesterol. Do you have metabolic syndrome? That's a word that's really describing multiple entities, such as an elevated sugar level, elevated blood pressure, and increased abdominal circumference or waist circumference. And so that we know will increase the risk having those factors of heart disease, diabetes, and even stroke. Chronic kidney disease has been associated with cardiovascular disease later in life, chronic inflammatory conditions, which I talked about. These are autoimmune conditions that are seen more commonly in women, like lupus and rheumatoid arthritis, but can also be seen in HIV. Again, this early menopause does come up, usually defined before the age of 40, and a history of preeclampsia, which usually occurs during or right after pregnancy, and it's associated with high blood pressure. For more research and funding going into research of looking at cardiovascular disease, we now know that there's some ethnicities that are at higher risk, such as South Asian. And finally, triglycerides, which is one component of that cholesterol panel that your physician or medical team might check if that's elevated. Again, all of these are individual risk-enhancing factors that you may or may not have that will be factored into those conversations with your healthcare team to decide next steps about reducing your heart risk. So by and large, absolutely, hands down, if you are smoking, the best thing you can do, and even vaping, we now know that there is associated cardiovascular risk with vaping, hands down is the best thing, the most impactful thing you can do to improve your heart health today. We recommend choosing a quit date, making a pledge of commitment, using your social support, friends, family to aid you in this journey that no one ever would say is easy, probably one of the hardest things to do. Just know that there are programs, and your providers might connect you with programs at Mass General and many other institutions, not only in Boston, but across the state, to help you quit and really provide you what you need to be most successful. Is that there's medications that are available, there's counseling, there's support groups. This is so vitally important. I cannot stress this enough, that in men and women, it's the same. Stopping smoking is the best thing you can do for your heart health. How can I lose weight? Well, again, this is just a general, this is a few 5 steps that I wanted to include. Please know it's very different, for different people. And there's weight loss programs both at MGH and across Boston and Massachusetts that can help you. But these are questions that I get asked a lot when I see patients in the office. So I always tell them, set realistic goals. Some will come in and say, I want to lose 150 pounds this year or 100 pounds. And that's great, but that's very hard to do. And if you're not successful, you can lose motivation. And that's why I tell them, one, let's just start out, what's your body mass index, which is why I brought that up earlier. Let's start there, and let's start, setting obtainable short-term goals. Sometimes a food diary, there's so many apps now that are available that can help you track what you're eating. Manage portion sizes. Smaller portions can help preventing eating too much. Because a portion is how much that you're taking in versus a serving size, which is actually what the nutrition label on foods is referring to. So we can control our portion size. The serving is what is on the nutrition label, and we can control how much of a portion that we're taking, because we know that obesity is rising and really is an epidemic, not only in this country, but in the world. And because adults are eating more calories per day, their portion sizes have increased. And though not during COVID as much, in general, Americans are eating out more, and the portion sizes in some restaurants can be 4 times than what someone would take in at home. So phytonutrients, one thing I tell my patients is that they said, how do I know if I'm eating healthy? Well, look down at your plate, and if it's the color of the rainbow, you're doing pretty well, unless it's candy. So I'm just going to say this is fruits and vegetables, because we know that phytonutrients will strengthen the immune system. We know from data, this is data that's on the Harvard website, that we now have data showing that these phytonutrients are potent anti-cancer and anti-heart disease effects. So try as much as possible. I certainly don't think any of this is easy, but again, making that intention to incorporate fruits and vegetables in every meal Some of my patients do smoothies or will blend these fruits and vegetables into other foods in order to increase those amounts of fruits and vegetables they're getting per day. So I tell patients, try to use whole grains, use healthy sources of proteins like nuts, fish, and seafood, non or low fat dairy, and if meat and poultry, try to use lean and unprocessed meat. Try to use non-tropical vegetable oil. You really want to minimize processed foods and added sugars as much as possible. I always encourage my patients to try to cook as much as possible because you can control what's going into your meal. You can limit the salt as well and limit alcohol use. So again, we're going into risk factors and how to address them, and just heart health is incorporating physical exercise. And people ask me, how much should I be doing? Well, again, it depends on everyone, and everyone comes from a different place. If you're not exercising regularly, I certainly don't tell you to start at line 1, 150 minutes per week, which is usually 30 minutes of moderate intensity aerobic activity 5 days a week. I tell them start again, just like the weight loss. Let's start slow. Let's have, very small obtainable goals. And then we build on that endurance and we build on that momentum to this goal of 30 minutes of moderate intensity aerobic activity, such as walking, elliptical, stationary bike, or any outdoor of those activities as well, for about 5 days a week. Then I add them to add moderate to high intensity muscle strengthening, like resistance or weights. Again, this is individually dependent on the patient. Try to stay active. We know that sedentary lifestyles are associated with an increase of cardiovascular risk factors. So get out, move around. Some of my patients during lunch will go take walks. Again, weather dependent, but it's a way of staying active and moving. And then, as I mentioned, you want to increase the amount and intensity gradually over time. I never want to have somebody who comes so motivated to do this, go out and do very intense activity and then hurt a joint or a tendon, ligament, and then they're back to square one. So it's better always to start slow and then build on that. And is there one better than the next? No. Do what you like, do what, that you enjoy. I would say if you can, do a variety of exercise, I think it keeps you from getting bored from doing the same activity. But again, this is limited again by the patient. Some patients have joint arthritis issues that, running and walking on a treadmill is just not going to work for them. So then we try things like water aerobics, if available at their local gyms. Stationary bikes is another option. So it really depends on what works best for you. But please remember, walking is one of the simplest things that we can do. It doesn't require any equipment. It can be done on most days, except for some of the tough New England winter days that we have here. And absolutely has been shown to improve heart health. So really, there's no best exercise. It's really what works best for you, something that you enjoy, something that you'll do consistently. Now, this is another one I get a lot in my office. Is alcohol good for my heart? So this is, it comes up quite a bit in the media. It's just as I say to the patients, it's coffee and the eggs, and is it good? Is it bad? Just know that there's no research that's really proven a cause and effect link between drinking alcohol and better heart health. There are components in red wine, there are flavonoids and other antioxidants that could potentially reduce heart disease risk, but know that they can be found in healthy fruits such as grapes and blueberries. It's best known to increase that good cholesterol that I mentioned earlier, or the HDL. However, just know that regular exercise actually will actually increase that HDL, and it doesn't have some of the harmful effects of alcohol. So that you will hear a lot of different things in the media. Again, really no cause and effect linked between drinking alcohol and better heart health. What about sleep? Yes, so sleep is very, very important for your overall health. I think all of us on the line know how we feel when we get a good night's sleep. We're energized, we're motivated, we're ready for the day. and how differently we feel when we don't get a good restful sleep. In general, we should be trying to aim for 7 to 9 hours per night. I'm gonna be honest, do I always do that? It's hard, but I certainly strive to do that as much as possible. So I don't think any of these things are easy. With the amount of time that we spend on our tech devices and notifications that go off in the middle of the night, the recommendations is try to not use the technology, which I have to smile because I think many of us are culprits to this, at least 30 minutes before you're trying to go to sleep, and not having that stimulation and brain activation that then we're asking our brain to slow down and go to sleep at night. Turning those notifications off if you can. Again, much easier said than done, but different sleep habits to try to improve your sleep hygiene. And what about stress? Well, stress is part of life, unfortunately, and as we know that life and the level of stress can be differently at all different times of our life. Also, the amount of stress that people have is certainly not the same, and the way people react to stress is not the same. But we now know that stress can lead to health problems. So what do I do to reduce stress in my life? I tell patients exercise. That's what I do. It works very well for me, but again, it's really what works best for you. Reading a book, listening to music, spending time with friends and family. Getting good sleep is a good way of combating that stress the next day on a good night's sleep. Trying to maintain a positive attitude and practicing relaxation techniques like meditation, yoga, really does work for some of my patients, and we know that it does work to reduce stress in patients' lives. Mental health, I cannot emphasize how important this is for your overall health. It can impact your physical health, and both positively and negatively. And stress and a way of dealing with stress, unfortunately, can lead to some bad habits that can be linked to heart disease and stroke, such as smoking, overeating, not exercising, even maybe not being compliant with the medications that your medical team has prescribed. So it can lead to bad habits. So recognition of the stress, addressing it, and finding ways that you can reduce it would be the best way if possible. Because the effects of positive mental health is all these great optimism, sense of purpose, mindfulness. But look, it also reduces, we have data now to show that it can lower blood pressure, lower sugar, less inflammation in your body, lower cholesterol. All of these reduce cardiovascular risk factors or cardiovascular disease in general. I'm going to wrap up with the treatment of cardiovascular disease in women, because I think this is an important part of Heart Health Month and Go Red for Women on Friday. So there's gaps, and that's okay, because this is, again, turning our attention brings intention to making a difference and changing these things. So women are underrepresented in clinical research investigating heart disease, and naturally this has slowed our progress in learning about key indicators of cardiovascular cardiovascular health in women. So the purpose of this slide is awareness and change is needed, not only in how heart health is studied in women, how it's taught in medical school, nursing school, and how it's treated. So this was a study that came out in 2020 that women represented less than 39% of cardiovascular clinical trial participants between the years of 2010 to 2017. And this does limit the potential for developing sex-specific strategies and recommendations for cardiovascular disease in women, which is why so many of us, not only at MGH, but across the world, are focusing our efforts in increasing women representation in cardiovascular clinical trials. And because of this, there are sex-specific disparities in management. As I mentioned, the clinical presentation might be slightly different in women. In general, though, they do present with chest discomfort, but they can have some of those atypical symptoms that I started out with. The cause of the heart attack might be different. There may be a delay in the recognition of a heart event in a woman, they may less likely get certain medications and procedures when compared to men, and they may be less likely to be enrolled in cardiac rehab, which is a very, very beneficial program for women who've had a heart event. And this is something that's been studied. This was a study that was published 2 years ago in patients who had a heart attack at the age of 50, less than or equal to 50. I want to point out that 81% of the participants in this study were men, and that in this study, women were less likely to be on the same medications and less likely to undergo a procedure. And unfortunately, in this study, did have an increased mortality. And the same has been shown with differences in the treatment of heart failure in men compared to women. So in addition to that, we have to recognize that there's social determinants of health and cardiovascular disparities in women. Certainly there exist in men as well. But if we want to focus on improving heart health for women, we also have to take into account their social determinants of health, their education, their physical environment. Do they have housing instability, limited access to green space, lack of healthcare insurance, economic stability, low income and debt, social support, culture and language is also an important thing that we have to recognize could be barriers to improving access to cardiovascular care for women and men, as well as sexual orientation, sex and gender bias. So we talked about what are the solutions then? So we talked about what is going on. So now let's talk about what solutions we can do in order to improve equity in care and improved outcomes. Well, we talked about public awareness. And again, programs like this are so important to increase the awareness that cardiovascular disease is the number1 cause of death in men and women. What are cardiac risk factors? What can I do to improve my heart health? Definitely we need some more sex-specific guidelines. And again, that are efforts that are ongoing throughout the world to make a change on this and an impact. We talked about the importance of sex-specific research and incorporating more women in clinical research studies for cardiovascular disease. And because it comes down to also the women's healthcare team in order to improve multidisciplinary care for our patients. And I interlock these circles because they're all dependent on one another. In addition to things I didn't cover today, such as leveraging technology, EMR, social media to get the word out there, sex-specific medical education. Let's look into the education of our medical students, nursing students, physician assistant students, nurse practitioners. Advocacy efforts, moving towards local and national government to make a difference in making sure that we provide equitable care for both men and women. And that's why we're fortunate at MGH and in many other centers across the world to have dedicated women's heart programs. This is one solution, not the full, in order to combat some of these issues that are impeding our progress in understanding cardiovascular disease in women. So improving funding for research, increasing awareness, improving access to care, growing these clinical programs, getting new data so that we can give our patients the best evidence-based care to improve their heart health. And finally, I'll just mention again our program. Again, there is many phenomenal programs across the country, across the state of Massachusetts, that are dedicated to women's heart health. The co-directors of our center here at MGH is Dr. Nandita Scott and Dr. Melissa Wood, which started this in February of 2007, again, to provide multidisciplinary treatment to address the gaps in clinical care, research and education surrounding cardiovascular disease in women. Over 5,000 women have been seen since it was started, with increasing number of new patients each year. I'm very proud to be part of this heart health program and making an impact in the cardiovascular health in our community. So my final points. First, again, I want to thank you for just spending the time with me during your lunch hour to discuss such an important topic and something that's very near and dear to my heart. So cardiovascular disease is the leading cause of death in men and women, not only in the United States, but throughout the world. It is so important to increase awareness of heart disease, as well as sex-specific risk factors by our patients and their clinicians. It's really essential. Optimal cardiovascular care for women includes a partnership of our patients, our women, with their medical team, their communities, as well as academic and community serving healthcare systems. There are disparities in cardiac outcomes. I bring that up because, again, this just tells us that we have more work to do. Many of us, all of us, are really ready to do this, to make a difference. It's important more than ever that we pay attention to the social determinants of health literacy. It's critical in understanding and improving care for our patients. Women's heart health programs like the one we have at Mass General and across the country is just one solution. It certainly does not solve all of the issues I brought up, but it is one important step to address these current gaps in clinical care, research, and education. And with that, I just want to, again, thank you so much. I'm happy to take questions, and thank you for the honor for allowing me to spend the day with you, or the noon time with you, and sharing some, I hope, was very important information for your heart health.
Thank you so much, Dr. Harrington.
Thank you.
We are now towards the end of the session, so if you have any questions for Dr. Harrington, feel free to enter them in the chat. So Dr. Harrington, we have a question regarding when should someone see a cardiologist and have routine EKGs?
Well, that's a very good question. A lot of the initial assessment of cardiovascular risk factors is usually started by your primary care physician, and starting out with that conversation first. They will usually, again, this is just a general, it can be different for every different health system. They usually will start the discussion. They will do some of those initial vital signs like a blood pressure and a heart rate. And as I mentioned, they will calculate your body mass index to know what is your weight normal? Are you overweight or obese? Then they usually will, again, dependent on the patient, will draw blood work to check that cholesterol level. If they feel that you need to be screened for diabetes, that's usually how they get initially started, is in the process. They may calculate that risk for that 10-year risk of cardiovascular disease. That's the calculator that I put up. So an EKG is not a very good screening test. It could be a little controversial, but in general, an EKG I will usually do in a patient who is having a cardiac symptom that I think is concerning. If I think that they might have an abnormal rhythm of the heart, I know they're done, very routinely for preoperative assessment when you're going for a procedure. But I think that's an individual, to do the EKG or not, I think is very much dependent on the patient, their risk factors, and their symptoms. And I wouldn't say it's just done routinely just to do an EKG. That you might find a difference of opinion on that, though.
Thank you. Can you share a little bit more about LDLs and how one can lower their LDL levels?
Well, such a great question, and thank you so much for bringing that up. LDL is one part of that cholesterol panel that it's also called the lipid profile, and it composed of the total cholesterol, that LDL level, that HDL level, that good cholesterol, as well as triglycerides and a few other components. The LDL has been and I would say all of it is important. The LDL has been associated with cardiovascular events and is a one target for not only cardiologists but primary care physicians as well. one of the most important things to do is decreasing your intake of saturated fats. So things that are very hard for my patients to hear, decreasing cheese. I have a lot of cheese lovers that when I tell them how much cheese are you taking in, a huge smile, I can even see it under their mask, and I actually will print out forms of and they put them on the refrigerator of foods that are high in saturated fats. And we try to stick to avoiding those as much as possible. Things like butter, things, any baked, as you know, baking cookies or cakes, we're all putting butter in them, and there's a lot of butter. So first steps is just recognizing what foods you're taking in. And again, I hope I drove this home today. It's not about going home and throwing everything out. It just doesn't work for practicing and taking care of patients for a period of time. Making small changes, ones that are obtainable and ones that don't seem so overwhelming that when they leave the office, they're thinking, oh my goodness, I can never have a cookie again. I just don't feel in my practice that works. So it's finding those foods that they might be taking in that are high in saturated fats and, really decreasing that as much as we can. And then finally, exercise is another fantastic way of reducing your LDL. If you're looking to lose weight, it does that. It reduces stress, it does that. So I'm a big proponent of exercise if you're able to. And for patients that see me in the office, we really try to find which one works best for them, because a treadmill is not going to work for some patients. And you really do want to pick something that's going to work for you, that you enjoy, and that you can try to do it consistently. So diet and exercise is the cornerstone of lowering your LDL. And then that's when you reassess that with your team. How am I doing? Am I making progress? And if not, sometimes we can talk about medications, that we have many, many medications that can control your LDL if you're struggling to do it with diet and exercise alone.
Sorry, I just muted myself.
I was just going to say, I think you muted, yeah.
What is the connection between thyroid disease and heart health? Is there one? If so, what's the connection?
Yep. So as the thyroid is one of the hormones, one of the glands that secrete hormones that's really important for our entire body, what we call homeostasis. It really keeps everything in check. Your temperature, your metabolism, it can affect your heart rate, it can affect your blood pressure, and it can affect your cholesterol levels. Although I'm a cardiologist and I love the heart, the endocrinologist will, the thyroid is so important as well in sort of maintaining everything at a steady state. So when I see patients who are having episodes of tachycardia or fast heart rate, or their blood pressure is high, or their cholesterol is high, and if their thyroid function is not normal, that is really the target first, okay? Because there is definitely a connection. There is so much more interconnections of, the brain, the kidneys, and everything with the heart. It's really it is a complete connection. And so if one is off balance, it will affect something else. And so for sure, that thyroid function, if that is a patient who's had a history of thyroid disease, that's got to be really fixed first. And then, and that's when, multidisciplinary team approach by touching base with patients, primary care physician or endocrinologist, let's get that under control, and then we'll take it from there. Most of the time things will settle down, but if not, I'm there to help out with whatever needs to be addressed. So definitely a connection, not for all, but would need to be part of the treatment. You need to treat both. You can't just treat one in isolation.
Thank you. And back to the previous questions, for those who are looking to make some lifestyle changes for heart health, what are some online resources that you can recommend?
Okay, thanks. Another great question. I cannot emphasize, as you probably saw on most of my slides, the data that's evidence-based data is coming from the American Heart Association. It is a phenomenal resource. And it's in very clear and understandable language. It doesn't use a lot of medical terminology. It also even has like recipes and things like that. I haven't tried them out, so but they look good and the pictures look good. just ways of, they talk about meditation, they talk about mindfulness, they talk about the mind-body relationship. I cannot emphasize, you will click on it and start clicking into other things and then into other things. And it is just a wealth of information about heart health. The American College of Cardiology has fantastic resources as well. The Harvard School of Public Health is also evidence-based, knowledge, information for patients in order to give them the facts about heart health. Because let's be honest, there's a lot of information going around with everybody with the best intention. What I tell patients is go to those websites because we know they're evidence-based. You're getting the facts and you're getting the latest research on how to improve your heart health. So great question. Thank you so much for bringing that up.
Thank you so much for a wonderful presentation. That's about all the time that we have for today. Before we end, do you have any final thoughts you'd like to share with the audience, Dr. Harrington?
No, I just can't thank you enough that this is such a timely talk to talk about heart disease, in the United States. Again, I just want to point out awareness is the first step. And although those statistics were daunting, awareness and these programs will reduce and make those curves turn in a favorable direction. I bring that up only to highlight the importance of the topic, but please note we can do so many great things to reduce all of those numbers that I shared with you today, and awareness is the first start. So programs like this, it's really an honor for me to be part of this. And thank you again for letting me spend a short time of your afternoon with you.
Thank you so much, Dr. Harrington.
Thank you.
And for everyone who joined us today, thank you so much for joining us. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. Will be available on the Blum Center website. You can visit us at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.